36-year-old man partying with his friends starts to try out IV drugs for recreation. After a few days of the party, he started to crave drugs, and he invites his friends to a drug party in his home. After some months, he notices a strange red colour spot on his palms and some nodules on his fingers, but he ignores it. After a few days, he started to develop fever, cough, and weakness. He went to see the doctor for the worsening symptoms. On examination, doctor found that patient had multiple needle tracks on his arms. On the palms, there were flat, painless red spots suggestive of Janeway lesion. On fingers, tender red nodules on the pulp of fingers were seen suggestive of ulcers node. On nails, there were hemorrhagic spots suggestive of splinter hemorrhage. On auscultation, a hollow systolic murmur is heard. This murmur increases in intensity during inspiration. Chest X-ray of the patient reveals scattered round lesions in the peripheral lung fields bilaterally. So here we have an IV drug user presenting with fever and cough. Examination shows Janeway lesion, ulcers node and splinter hemorrhage. On auscultation, a hollow systolic murmur is heard which increases during inspiration. What do you think the diagnosis is? 1. Infective endocarditis with tricuspid valve abnormality. 2. Rheumatic heart disease. 3. Pneumonia. 4. Aortic stenosis. 5. Mitral regurgitation.
A 36-year-old man comes to the emergency with history of fever, cough and generalized weakness going on for the last 3 days. On examination, you find that he's got tachycardia. His blood pressure is 130 by 90 mm of mercury. On further examination, you note multiple puncture marks on both his forearms. There is also an erythematous macule in both his palms, along with painful, tender nodules on the pulp of his fingers. You also notice splinter hemorrhages on the nail beds. On auscultation, you hear a hollow systolic murmur that is best heard in the left parasternal area, and this murmur increases on intensity during inspiration. An X-ray is done, and there are multiple nodular infiltrates on both lung fields. Now, let me walk you through the history and the examination to help you make a diagnosis. The history of fever and cough doesn't contribute to much. It may just be an upper respiratory tract infection or the beginning of a pneumonia. But what helps us clinch the diagnosis are the peculiar clinical findings in this case. The erythematous macules that we see on the palms are what are known as Janeway lesions. The tender nodules on the pulp of the fingers are what are known as Osler's nodes. This combination of Osler's nodes, Janeway lesions, splinter hemorrhages, and a person who is suspected to be an intravenous drug user, along with the murmur that you hear, points us to the likely diagnosis. Yes, you're right. We are talking about this patient having infective endocarditis. Now, infective endocarditis is an infection of the endocardium. We know that the endocardium is the innermost layer of the heart. The most common affected structures include the valves. Sometimes other cardiac structures such as implanted pacemakers or defibrillators may also get infected. And rarely even the mural endocardium can get. Based on the temporal evolution of the disease, infective endocarditis can be classified as either acute infective endocarditis or subacute infective endocarditis. Acute infective endocarditis is a rapidly progressing disease. It causes a lot of destruction of cardiac tissue. There's an increased chance of hematogenous dissemination along with embolization of vegetation. And if it is not treated on time, it is invariably fatal. Subacute endocarditis, on the other hand, is an indolent disease. Destruction of cardiac tissue is slow, and the chance of embolization is lesser. Now, not everybody does get infective endocarditis. There are certain predisposing conditions which increase the likelihood of a person developing infective endocarditis. Patients with congenital heart disease, for example, ventricular septal defects, chronic rheumatic heart conditions like mitral regurgitation or aortic regurgitation or even aortic stenosis, patients who are illicitly using drugs, patients with degenerative valves, and patients who've got implanted pacemakers or defibrillators. these patients are most likely to get infective endocarditis. Now, coming to the etiology of infective endocarditis. There are many bacteria and fungi which can cause this infection, but majority of the cases are caused by a few bacteria. Let me list them out for you. First is streptococci, especially viridin streptococci, enterococci, pneumococci, Staphylococcus aureus, coagulase negative staphylococci, and the Hayseck group of organisms. The first 5 bacteria are gram-positive bacteria. The Hayseck group of organisms are a group of fastidious gram-negative coccobacilli. This acronym stands for H stands for Haemophilus species, A stands for Aggregatibacter, C for Cardiobacterium hominis, E for Eichinella corrodens, and K for Kingella. These names are not very common, but they are strange and unique, so I think you should be able to remember them. Now, there are certain clinical conditions which increase the likelihood of a particular bacteria causing infective endocarditis. For example, in our case here, a person who was suspected to be an injection drug user, the most likely type of endocarditis is a tricuspid valve endocarditis. And the most commonly implicated bacteria is Staphylococcus aureus. Another example is prostatic valve endocarditis happening within 2 months of valve surgery. Here, the most commonly implicated organism is a nosocomial infection, most commonly Staphylococcus aureus, coagulase negative staphylococci, and gram-negative bacteria. If you have to understand the clinical features, you have to make sense of the pathogenesis of this disease. Now, the endocardium and the endothelium are generally resistant to infection, unless of course they are damaged. Sometimes the endocardium may be exposed to high velocity jets of blood, resulting in trauma to the endocardium. Most likely what happens is the development of a platelet fibrin thrombus at this site. This uninfected platelet fibrin thrombus is also referred to as non-bacterial thrombotic endocarditis. Over a period of time, sometimes when there is transient bacteremia, now remember, bacteria can enter from the mucosal surfaces, from the skin, or from focal sites of infection. This transient bacteremia may seed this thrombus. This infected vegetation is the prototype lesion in infective endocarditis. There is microbial proliferation happening at the site of the vegetation, and bacteria then gets disseminated into the bloodstream from this vegetation. The clinical features of infective endocarditis hinge on 4 predominant pathophysiological processes happening here. The first is the extension of infection in the cardiac structures. The infected vegetation can spread around the valve and can extend even to the pericardium as well. There can be hematogenous dissemination of infection. Sometimes the vegetation may embolize to distant sites, for example, the brain or the spleen. And lastly, there can be circulating immune complexes which cause damage to tissue. Remember, the bacterial antigens will evoke an antibody response, and this antigen-antibody complex can get disseminated and cause damage to distant tissues. Circulating immune complex deposition in tissues, such as the glomerular basement membrane, causes glomerulonephritis. Deposition of these complexes in the capillaries of the finger activates complements and neutrophils, resulting in inflammation of the pulp space. This tender nodule is called the osseous node. Similar inflammatory changes in the capillaries of the nail bed causes hemorrhagic lesions under the nail, commonly referred to as splinter hemorrhages. Roth spots are white-centered retinal hemorrhages occurring due to endothelial dysfunction leading to retinal capillary rupture. These are again secondary to immune complex deposition. Now, coming to the clinical features of infective endocarditis, I'll classify them into 3 types: constitutional symptoms, cardiac manifestations, and extracardiac manifestations. The constitutional symptoms of infective endocarditis are similar to what we see in any other infection. Patients may present with fever, with chills, weight loss, nausea, anorexia, myalgia, arthralgias. The cardiac manifestations are more interesting. I told you that the typical lesion is an infected vegetation. Now, this vegetation can grow. The bacteria can proliferate, resulting in the development of perivalvular abscesses. The infection can reach the pericardium and the person may have features of pericarditis. Valvular damage may result in either a new murmur being heard or worsening of a pre-existing murmur. Either ways, patients may present with features of congestive heart failure. The non-cardiac manifestations of infective endocarditis are equally interesting. Let me take you from head to toe and tell what these manifestations are. Infected emboli can go to the brain and a patient may develop stroke. Alternatively, there may be a development of mycotic aneurysms. Please don't be mistaken, this is nothing to relate with fungi. Mycotic aneurysms are focal dilatations that develop on the wall of the arteries because of infection. These aneurysms may rupture, resulting in the development of an intracranial hemorrhage. Patients may also come with features of meningitis. In the eye, there's a peculiar finding. Rod spots are hemorrhages seen on the retina surrounding a pale center. There may be conjunctival hemorrhages seen. Coming down to the hands, we discussed about Janeway lesions. These are erythematous macules on the palms. Osler's nodes are tender nodules that are felt on the pulp of the fingers. Please remember the 4 P's that I'm going to tell you. They are painful, found on the pulp of the fingers, pea-shaped, and they seem purplish in color. Now, there are other interesting findings that you look in the fingers. Splinter hemorrhages are seen on the nail beds, and you may also find clubbing here. Patients may complain of abdominal pain, and when you palpate the abdomen, you find tender splenomegaly. In the case that we discussed above, we have a person who's suspected to be an injection drug user. These patients are more likely to develop tricuspid valve endocarditis. Vegetations from the tricuspid valve can embolize to the lung. So patients may present with fever, cough, breathlessness, chest pain, and sometimes even a pneumothorax. Now, the diagnosis of infected endocarditis is made easy by the modified Duke's criteria. Now, what is the modified Duke's criteria? There are a set of criteria, major criteria and minor criteria. The first major criteria that needs to be fulfilled is the presence of positive blood cultures. Typical organisms, when grown in 2 consecutive blood cultures, are very strongly indicative of infective endocarditis. Please remember, we need to take at least 3 sets of blood cultures from different venipuncture sites, and these should be separated by at least 1 hour apart. The reason why we take so many blood cultures is to demonstrate ongoing bacteremia. The second major criteria that has to be fulfilled is the presence of endocardial damage, and this is picked up by doing a 2D echocardiogram. Now, normally a transthoracic echocardiogram is enough to pick up vegetations and to see if there is any other damage. But sometimes the vegetation may be very small, or there may be valvular abscesses which may not be picked up by the transthoracic echocardiogram. In such cases, the transesophageal echocardiogram is most essential. Coming to the minor criteria, there are 5 of them. Presence of fever more than 38 degrees Celsius, the presence of a predisposing condition, for example, a person with a congenital heart disease, or in our example, a person who's been using illicit drugs. The presence of vascular phenomena. By vascular phenomena, I mean the arterial emboli that spread to different parts of the body. Janeway lesions are also vascular phenomena. The presence of immune complexes. Rod spots, Osler's nodes are typical of immunological phenomena. Now, to make a diagnosis of infective endocarditis, you need to have either 1 major and 3 minor criteria, or 2 major criteria, or all 5 minor criteria to be present. In addition to this, we also need to do certain other lab investigations. We need to do a complete blood count. You might notice this patient may be having anemia, There may be leukocytosis. There may be an elevated erythrocyte sedimentation rate. Renal functions may be compromised because glomerulonephritis can be present. A urine analysis may reveal microscopic hematuria, which indirectly points to underlying glomerulonephritis. We also need to do an ECG, which may pick up heart blocks, and an X-ray, which may show nodular infiltrates like we saw in our particular case. These infiltrates are happening because of septic pulmonary infarcts. Coming to the treatment. Now, treatment is decided upon the clinical situation that we are dealing with. If the patient is sick, requires urgent antibiotics, we need to give them empirical antibiotics. Now, if it is a native valve endocarditis, the empirical treatment that we start normally is a combination of vancomycin with ceftriaxone. If we are dealing with a person who's got a prosthetic valve endocarditis, we give a combination of vancomycin, gentamicin, and rifampicin. Tricuspid valve endocarditis, which is seen most commonly in injection drug users, can happen mostly because of either methicillin-sensitive Staphylococcus aureus or methicillin-resistant Staphylococcus aureus. For MSSA, the drug of choice is either nafcillin or oxacillin. For MRSA, the drug of choice is vancomycin. In patients we suspect to have Hayesick group of organisms, the drug of choice is ceftriaxone. Remember, the final therapy is tailored after we get our blood culture reports. Most antibiotic regimens are given for a duration of 4 to 6 weeks. Now, we've discussed the medical management of infective endocarditis, but there is also a role for surgical treatment. Surgical treatment is indicated in the following conditions. If there is a perivalvular abscess, if there is a large vegetation with a high risk of embolization, if a patient is not responding to antibiotics and is consistently having fever, or a patient who develops heart failure because of either a new or a worsening valve dysfunction. In these conditions, we may have to consider surgical therapy. Coming to prophylaxis for infective endocarditis. Now, there are certain conditions or certain high-risk cardiac lesions where we consider giving prophylactic antibiotics essential. What are these high-risk cardiac conditions? Patients who've already got previous endocarditis, patients who've got an unrepaired cyanotic heart disease, the presence of a prosthetic valve, and new valvulopathy developing after cardiac transplantation. All of these are high-risk cardiac lesions which require antibiotic prophylaxis. Now, the procedures which require prior antimicrobial prophylaxis include any procedure that has to do with manipulation of the gingival tissue, procedures which relate to incisions of the respiratory mucosa, and any procedure relating to skin infections, for example, an incision and drainage of an abscess on the skin. All of these procedures have a high risk of producing bacteremia, which may result in the worsening or development of infective endocarditis. Now, what are these antibiotic prophylactic regimes that we are discussing about? They're very simple. These antibiotics need to be given to the patient 30 to 60 minutes before the procedure. Patients can be either given an oral dose of amoxicillin, 2 grams. If the patient cannot take oral antibiotics, we can give them injection ampicillin 2 grams IV. If they're allergic to penicillin, clindamycin and azithromycin are reasonable alternatives. To summarize whatever we've learned today, please remember all the peripheral signs of infective endocarditis because they may be the only thing that may help you make a diagnosis. Remember all the cardiac manifestations and also the modified Duke's criteria which help us in making a diagnosis. Remember, you need to have either 2 major criteria or 1 major along with 3 minor criteria or all 5 minor criteria for you to make a diagnosis of infective endocarditis. The treatment is important. Please remember, if the patient is critical, if the patient is sick, you may have to give them empirical antibiotics. Otherwise, you can wait for the blood cultures to come to start antibiotic therapy. At least 3 sets of blood cultures need to be taken to demonstrate ongoing bacteremia. Please remember all the conditions that we discussed about for the need for surgical therapy. And lastly, please remember all the antibiotics that we discussed for antibiotic prophylaxis prior to either dental procedures or skin procedures.